All right, well, I'm going to go ahead and get us started because I know we have a lot of great content today and we want to make sure we leave time for questions. So, good afternoon, everybody. I am Jennifer Muthig, NYSARH's Executive Director. And on behalf of the New York State Association for Rural Health, I'm really thrilled to be able to facilitate today's webinar, Community Paramedicine in Action. We have two outstanding presenters with us today, Mark Spezio, who's Chief of Operations at the Cambridge Valley Rescue Squad, who I was fortunate enough to partner with on a community paramedicine project in rural Washington County, and Aidan O'Connor, Executive Director of Greenport Rescue Squad, who I was fortunate enough to spend last week in DC with, advocating on advancing rural healthcare policies on Capitol Hill. So today's session will focus on how community paramedicine programs are improving healthcare access in rural communities and how these models can help reduce unnecessary hospital and emergency department utilizations through in-home paramedic visits. So before we get started, I just have a couple of housekeeping things. You'll notice we have our NYSARH 2026 symposium that will be held in Clayton, New York on September 17th and 18th. Stay tuned for more information. We will be opening up call for abstracts and our keynote speaker, which I'm working on finalizing this week. I did confirm that we will have Karen Madden with us from the Department of Health to talk about the Rural Health Transformation Program, what went well the first year, what maybe could have gone better, and how do we continue to partner together to make sure that rural is being represented in the process. So keep an eye out for those. The Public Health Partnership Conference is now accepting student posters. Submissions are due by February 27th at 5 p.m. The conference will be held in Lake Placid, New York, April 22nd to 24th. And Holly will drop the link in the chat. So if you want to take a look to submit one of those posters. And please feel free to share with your networks as well. Our next webinar here with NYSARH will be March 19th on healthcare workforce preparation with Chris White and Valerie Gray. You will learn about how SUNY is playing a key role in preparing the next generation of healthcare professionals and ensuring those currently in the workforce are prepared for changes in technology, automation, and artificial intelligence. And Holly, if you don't mind just dropping that into the chat as well, please. As always, NYSARH is proud to be able to offer CHEST credits for you. And then additionally, new in 2026, we are offering continuing education statements for physical therapy and occupational therapy. So we're really thrilled to be able to add that this year. So again, just disclosure for learners, here are our activity title and our learning objectives that Mark and Aidan will go through. And then Aidan's going to take us through as well towards the end on some state policies and federal policies that are occurring. And then we'll go ahead and do an evaluation towards the end. And then I'm going to go ahead, Mark and Aidan, and pull up your slides and turn everything over to you. If folks do have a question throughout the process, feel free to drop it in the chat. Mark and Aidan are happy to answer questions in real time or wait till the end, whatever is most authentic to you. But I'm going to go ahead and pause now, and Mark, turn it over to you to kick us off. Thank you.
Thanks. Aidan, you have any opening comments, anything you'd like to share to get things moving?
No, I'll just say, as a board member of the New York State Association for Rural Health, as well as my placement in EMS, I could not be more thrilled to have Mark here. I'll echo Jen's comments. He's such a perfect subject matter expert right here in New York State in the rural environment and how EMS is making that impact. So just great to be with you, Mark, and great to be with you, Jennifer, today.
Absolutely. And I'll start off with those pleasantries as well. Both of you have been great partners on a variety of different things for a number of years, and it's really exciting to partner with you on this and to reconnect and to bring you community paramedicine and its rural impact on rural healthcare. So we can bounce to the next one if you don't mind, Jen. So these are the objectives for today. Basically we're just going to take a really quick stroll through community paramedicine, especially how it impacts rural communities, and what it is we actually do. Some of you may know, some of you may not know. Looking at the people that are enrolled today or that are participating today. Lots of familiar faces, some folks that I see on a monthly basis at various different meetings, some folks that I haven't seen in quite a while. Hi, Nancy. That shout out was to you. And thank you for the true kick in the pants to get this thing rolling a good number of years ago. So let's get started because there's lots to talk about. So just a couple of things really quick. One of the other hats that I wear is I have sat on the New York State Department of Health's stakeholders work group to develop the regulations for community paramedicine. Article 3018 of the public health law was passed in 2023 that gave permission as the first permissive legislation for community paramedicine to exist in the state. And we spent the better part of 2025 drafting the regulations that we'll talk about towards the end here as they're getting ready to come out for public comment. But just a couple of terminology things to keep everybody apprised of so we kind of understand what the conversation is about. Is there is a slight difference between mobile integrated healthcare and community paramedicine. Mobile integrated healthcare, MIH, is really kind of the umbrella of what we do. And that's when we integrate EMS with primary care specialists, hospitals, home health care, all of the resources that are out there. That's kind of the umbrella, how we integrate it and bring it. Community paramedicine is the EMS part of that. It's, taking that and then doing the things that we do, with the patients in the homes to do, at the end of the day, the whole purpose of this is to reduce unnecessary hospitalizations, whether it's ED access or it's, actual admissions into the hospital. Just real quick at the bottom, the New York State timeline. There was a few of us that were doing this before it was a thing. Community paramedicine has been around since about 2008, 2009 in the United States. Really came out of the Affordable Care Act along with the EMS Agenda for the Future 1996, which really identified EMS as being more closely aligned with public health than with public safety. So those kind of things meshed, and then we started to see this community paramedicine concept develop nationally. 2015, we started to see the groundswell of it, or the beginnings of it, within New York State. There were really 5 programs that started to work independently on addressing community paramedicine issues in their communities. Cambridge Valley, or us in Washington County, being one of those 5. Between 2015 and 2020. We did a variety of different things. We finally all connected as 5 groups. We shared stories. We had some symposiums to create best practices. We found the workarounds with public health law at the time to allow us to do this without getting in trouble, et cetera, et cetera. Fast forward to 2020, we had that little virusy thing that kind of screwed things up for a couple of years. And that's really where we saw community paramedicine have to take place. And I will say, if it wasn't for the first 5 in, if you will, if you're an NCAA fan and you're getting ready for March Madness, like those last 4 in, well, we were kind of the first 5 in. The first 5 really, I think, were the groups that pushed the Department of Health very hard to get EMS to be able to do things like testing and vaccinations. A workforce that was out there, that was readily available to be used to address these things. So the Executive Order 05 or 04, as part of community, or part of the response to COVID, specifically identified for the first time in any legal document in New York State the need for community paramedicine. And from late 2020, which opened up community paramedicine basically for vaccinations and for testing, through early 2023, when permissive legislation was actually signed, community paramedicine was really all about getting us through the COVID pandemic. 2023 legislation was passed, signed by the governor, which is Article 3018 that I talked about before, which created 50 pilot programs to be established within the state and to develop regulations to then, follow for the implementation guidance, kind of the soup to nuts on how CP should work in the state. So 2023, the original 5 programs were approved. 50 programs that were doing vaccinations and testing within the state were approved. We all received letters from the Department of Health saying, God bless you, you're doing the right thing. Keep doing community paramedicine. And that's really where we are from a legal perspective to today. There's 55 approved programs in the state. We're approved to do whatever we were asked the Department of Health to allow us to do initially. And we continue to progress. We'll talk more about the legislative and the legal aspects of it, but that's a real brief history of how things came to be within New York and where we are today. So really, community paramedicine is about filling the gaps. Like a lot of the things that we're all doing in rural healthcare or any healthcare, we're just trying to plug holes in the system that we all know is fragmented and is incredibly difficult to navigate. So what CP is about is filling the gaps. We're not trying to recreate the wheel. We're not trying to do something that already exists. We're not trying to jump into anybody's space. And I think that's a critical component of this is we're just trying to plug in the gaps so that we keep people safe, healthy at home, and keep them out of the emergency rooms, out of the hospital unnecessarily. So, and then there's all the benefits that come from that. So one of the objectives is how do we improve access to rural healthcare through this? Well, we all know that the need greatly outpaces the resources that are available, whether it's home healthcare, it's primary care, it's specialists, transportation, especially in the rural counties. That has been identified in our county for a number of years in our community health assessments that transportation just to and from primary care appointments is one of the biggest issues that we find. So we know those needs are far outpacing what we have for resources and what we have for funding. The further you get from a population hub, we also know that the less likely you are to receive any of those in-home resources that may be available for you. So EMS is there. It's a resource that already exists in every single one of these communities. Now, we have seen a lot of transition in the emergency part of EMS. You know, there's been workforce issues, there's funding issues, there's all of those things. But through the work at the state level, at the local level, especially with counties, we're seeing that trend reverse and somewhat quickly to address those needs. One of the areas that is being addressed, you know, in some of these counties and municipalities is the true implementation of community paramedicine programs to augment and supplement the 911 system so that we reduce the reliance on 911 for truly unnecessary calls. I'm going to give you an example here in a minute. I think it's going to blow your mind. So again, we're there. We're not changing our scope of practice. We are doing things that are within our scope of practice. We're just expanding that role to do it in a non-911 setting, in a more scheduled person-to-person scheduling or person-to-person, patient-to-provider type setting where we have time to work with these patients. The other thing that we've found too is that in community paramedicine programs, EMS is a trusted, flexible resource. We're a 24/7 operation. These people, you know, these patients don't have any problem calling us at 3 o'clock in the morning to come into their bathroom to pick them up. So when we walk into the home, it's not abnormal. It's something that people expect, and that we have that kind of built-in, I guess, trust right away. So how does it work? I picked this. There's a quote there. My screen is kind of blocking. I'm not going to read the quote, but I grabbed it off of the CDC website specifically about community paramedicine. And again, it talks about exactly what we do. It's being there for preventive medicine, addressing social determinants of health, and helping people be safe and be healthy at home without having to rely on emergency departments for their day-to-day health. How do we do it specifically? We spend time with our patients. In a 911 setting, we're there 15 minutes. In a primary care setting, they're with their primary care physician 15 minutes. When they're with a specialist, they're there for 15 minutes. Most community paramedicine interactions last anywhere between 30 and 45 minutes, and that's without performing a skill. That's just completing the assessment and educating and working with the patient on their specific needs and their healthcare plan. We listen, we educate, and we follow up. One of the things that I have found, tremendously, satisfying with community paramedicine is how all of community paramedics, whether it's in our shop or anybody else's shop, advocate for these patients. Not only do they make phone calls to primary care, we've had community paramedics that will leave call their next patient and say, I'm going to be late. I can't get through on the phone to the primary care, and drive to the primary care's office to actually, sit with them and say that we have a problem, how are we going to fix, this patient's issue? A lot of times we're catching stuff before it becomes a thing, and that is huge. That's one of the biggest ways to keep people out of the hospital, whether it's a 3-pound weight gain for a CHF patient or a patient that's bedbound that is showing signs of a potential UTI. Much better to find a UTI on a home visit on a Thursday afternoon than it is to have to call 911 on a Saturday evening because the patient's now septic. So again, wide range of things we do, and we provide a real hub for referrals. I just this morning worked with one of our community paramedics to connect them with some resources from the Alzheimer's Association, not for the patient, but for the caregiver, because the utilization for 911 is the caregiver calling 911 because the patient is sundowning. Has nothing to do with the patient actually needing some medical need for an ambulance. So again, becomes a big source of referral out as well. Again, I go back to, is this really a thing? Because sometimes you have these new and interesting, programs and such, and, they become a flash in the pan. Again, just doing a simple search of community paramedicine or data on community paramedicine, boom, this article pops up as one of the top ones. And when you look at it from a national perspective, there's all kinds of policy recommendations and recommended legislative actions on the national level as well. So from the national rural health policy perspective, things like, enabling legislation for CMS to allow this to be a billable service, a fee-for-service type of program, which would be tremendous for financial stability and sustainability of the program. So again, lots of things not only happening locally, but happening nationally as well. So how does it more specifically work? Well, we integrate our, the core health system with practitioners. We're in the community, and that's the mobile integrated healthcare part of it, is we're able to look at the system, we're able to work with the system. Again, we get referrals, and all systems do, from hospitals, primary care, specialists, home health care agencies. We work specifically in our program with three different CHAWs that all make referrals. We get referrals from our county office of the aging, from public health. I received one today from a home health village that is making a referral for a patient. So we're able to integrate, with all of those entities, and by building those relationships, we now have this huge wheel of referral in, referral out, communication loops, those kinds of things. We certainly serve as a bridge in transition. We do get a fair number of referrals for patients that are being discharged that are going to go eventually have home health aides, or home health nursing rather, but it's a week out, it's 10 days out because of workforce issues, because of transportation issues, because of those kinds of things. We can easily bridge that gap for a week until the CHAW can go in and start providing services. Certainly communication, access, and continuity of care, is huge. We're able to communicate with across the bandwidth with all of those services. So everybody is in communication with what's going on with the patient. Preventable hospitalizations is the number one. That's the priority. That's what we look to strive to do. And the data is pretty clear that we're able to do that. I'm going to show you a couple of data points here in a minute. Decreased 911 utilization. How do we do that? We educate. That the biggest thing we can do is teach people how to take care of themselves. And we're not constrained at this point by an insurance plan that says you have 3 visits or you can only go in for 6 weeks. Well, the patient still may feel lousy for the first 3 weeks of that 6 weeks and may not have the opportunity to make those changes, to do the motivational interviewing that we need to do, to address the social determinants of health, to do those things to get the patient to where they need to be. And I think it gives for a more holistic approach. If the patient wants to do this, and we're able to educate the patient to do it themselves, that's a win for all of us across the board. And the data, again, supports it. Specifically, what are some of the things we do? Chronic disease monitoring, education, and management is the number one. Not terribly sexy as far as going in, as compared to a 911 call where you're bringing in your toolbox with, 75 meds and, potions and pills and those kinds of things. But just teaching people how to use their nebulizer, teaching people how to properly take their weight, having a CHF patient understand the relationship between sodium intake and their exacerbations. All of those things are critical. So that's where we spend a lot of our money. Certainly, we do the 3 assessments. Not only do we do the medical assessment, but environmental assessment and social assessment. The number of referrals that we make to programs like HEAP, Meals on Wheels, SNAP, those kinds of things, just to get the patients the services that they don't know, but they need to be able to do all of the other things. The number of times we refer patients to a food bank, just again, so they can get nourishment, so they're able to address their, and manage their diabetes. Medications continues to be a big part of what we do. Med reconciliations, med management, we do it all the time. I actually had a patient, just a real quick sidebar. I had a patient that I've known this gentleman for years. He's incredibly active. He's an active volunteer firefighter. He's a retired state trooper. He does all of this. He was referred by his primary care. He has Parkinson's now, very, very well managed. He still does well on his own. But he was referred because he has a VA doctor. He has his primary care. He has his specialist, his neurologist, and he can't figure out his meds. And this guy is bright. So I went in one visit is all it took. Went in, we sat there, we spent an hour and a half doing a med rec. We took 3 medication lists. We took what he actually had on hand. We laid everything out. We identified 6 medication issues. That one of them, just a simple one, was having some pretty significant neuropathy pain at night. He had gabapentin. He physically had the script. It was prescribed by the neurologist, but did not appear on either his PCP's list or on his VA doctor's list. So he stopped taking it. And so again, addressed, corrected, one visit, we got things straightened around and perfectly fine now. We do post-discharge follow-up, especially, on a significant, and not just this is across the board. Post-discharge follow-up is one of the most significant ones, especially ED dismiss or discharges, especially programs in the southern part of the state, lower Hudson Valley, are doing tremendous work with post-discharge patients, reviewing discharge instructions, making sure patients have their medications, making sure they're safe at home, all of those kinds of things, because we know the first 30 days is the highest likelihood that a patient's going to be readmitted to the hospital. Fall prevention education, we bring technology to people's homes to help them with telehealth appointments if necessary. Lab testing, we do I know our program and every other program does a ton of lab draws. We're bringing, we're drawing labs at home for homebound patients that can't get out, and we're bringing them to the local lab. We're grabbing urine tests. We've done stool samples. We've done sputum samples for patients with home vets, those things. From a where do we go from here perspective, I sit on a state emergency medical council committee where we're working with the Wadsworth lab to kind of change some of the definitions on testing so we can be able to bring more point of care testing to community paramedicine. Great example, a patient with a CHF exacerbation that fits into a certain criteria, we should be able to medically take care of them at home by increasing their oral or their IV diuretic. However, in order to do that safely, we need to know their potassium level. Well, we have to draw the blood, we have to bring the blood to a lab, we have to wait for it to be analyzed, and in that time period, that patient could significantly get worse and require hospitalization. So if we're able to draw the lab at the scene and analyze it at the scene, and then given certain parameters and protocols, we'd be able to manage that patient there. So we're really hoping that will, those regulations will change in the very near future. It'll be a very big win for community paramedicine and as a whole. Wound care, I know in our program and many other programs, we are doing an absolute ton of wound care. And then we do ostomy changes, catheter maintenance, whether it's replacing Foley catheters or dealing with, catheter issues that might be at home. And again, patients that may not have other sources, other caregivers or home nursing that is taking care of that. Here's some data. On the left, this is data from some, a 7 regional project that's happening right now within New York State. Year 1 data collection saw a 61% decrease in hospital visits. Year one also saw a decrease of 78% in hospital admissions from the data collected. Add a couple of more programs to it, add a couple of more years to it, and the numbers are outstanding. So in that program, in those 7 regional programs, which I know at least 3 of them are county-wide programs, 4 of them are county-wide programs. The others are regional, and some of them just getting kind of kicked off. Almost 70% reduction in emergency room visits over a 6-month period for these patients, and a 76% decrease in hospitalization. Now, that also includes your patient that has a chronic disease that goes to the hospital because they had a stroke, or they had an MI, or they fell and broke a hip. So that 76% includes those. It doesn't necessarily differentiate between unnecessary. That data includes any reason that they went back to the hospital. So, those are significant numbers, absolutely significant numbers. And when you look on the other side of it, not only does it reduce the utilization of the EMS system, ED overcrowding substantially reduced when you have good community paramedicine. Think about the healthcare dollars that are saved here. I mean, that is right there. When you look at and then you start putting numbers behind this, we're not talking 70 out of 100 patients. We're talking 70% out of thousands of visits. You're talking millions of dollars in healthcare related costs that have been saved because of CP work. Case study. This one actually isn't one of ours. This comes from a colleague of mine who runs a very large community paramedicine program in the Hudson Valley through Empress EMS. So 42-year-old female, this case study was actually published just recently. 42-year-old female stays at home with her partner, lives with her partner, not a great section in Westchester County. History of asthma, substance abuse disorder, hasn't seen a doctor in a long time for a whole lot of reasons. High system utilizer, generally calls for asthma exacerbation, refuses to go to the hospital about 50% of the time. So either they're treating in place, or she just plain out just wants to be assessed, or the other 50% they take her to the ED. So she's enrolled in the program. She actually is enrolled in the program 1/1/25 upon a discharge from the hospital. First interaction with CP, she's coached on her chronic disease. They talk to her about her asthma. They go over her discharge instructions. They emphasize medication compliance. They teach her how to use her nebulizer, accurately or more effectively, those kinds of things. So they start following up. Weekly visits then ensue. They are able to get her new nebulizer equipment, even though she doesn't have a PCP, get rid of kind of probably the old moldy, worn out stuff. And they really start setting her up for self-management. So as they get that, and we found that any community paramedicine program sees this, as you follow up with your patients, you get to learn more and more and more about them. And you develop that trust, and you develop that really, you really can get into the whole motivational interviewing aspect of it. So through the interviews, they find this patient had a TBI when she was 16. Again, that's going to lead to a lot of, high utilization. We know that those two go hand in hand. They find more. Her ACEs score is 5, which is up there. That's a big red flag. They also identify 3 high-risk social determinants of health with this patient, in addition to the ACEs score. So no wonder this patient was a high utilizer. This patient, lack of a better way to put it, is a train wreck. She's got chronic diseases, which are now uncommon with a high ACEs score. She's got, social determinant issues. She's got the TBI, so no wonder. Here's what this is like, case study 1 of any community paramedicine program. The 2 years prior to inclusion in the CP project, she averaged calling 911 for EMS 4.5 times a week. 4.5 times a week, she dialed 911 for an ambulance to go. Of that, she went to the hospital twice. So 2.25 times a week, this patient went to an emergency department for an exacerbation of asthma. She's been in the program 60 weeks. She has called 911 exactly 1 time. Not 1 time a week, not 1 time a month, 1 time in those 60 weeks. So that's how this program works. No other program was available for this patient. Nothing else was available except community paramedicine to work with this patient. Yeah, I agree. You know, the thumbs up, the clapping, all the emojis. Yeah, it's just really, really great stuff. So Aiden's going to talk a lot more about this in a minute. Just real quick on the legends, where do things stand today? Public health law, I talked about that. Very soon, the draft regulations are complete. One of the things that DOH is now doing with any new regulation is they're also putting their guidance document with it, kind of their playbook. So you have the regs, and then this is how you actually do it with, you know, best practices, yada, yada, yada. So that's what's being finished up now. Probably sometime within the end of Q1, early Q2, the proposed regulations are going to go out for public comment. Historically, there has been only one group that has really opposed community paramedicine statewide. We have had representation from that group on the 3018 stakeholders group. So we're really hoping that what we've created is going to have very little opposition. But what I would say is, you know, for those of you that have commented here or that take this presentation or have heard, you know, Aiden, myself, Jennifer, anybody else speak on community paramedicine, and you feel that you're a proponent of it, really would like you to advocate once those regulations come out. Kind of the plan is first round of regulations, and then first round of regs come out, public comment, go back to the drawing table, then send them out for second round. Hopefully by this time next year, they are in the commissioner's hands for signature. So that's it on that. Just please advocate, and I will definitely push it. I mean, Aiden will see it right away, but we'll definitely push it out to Aiden and Jennifer to push it out to you folks when it's posted.
Mark, did you want to address a question before we turn over to Aiden on the legislative portion? Andrea asked, have you done any work in the pregnant or postpartum period, performing blood pressure checks or neonatal assessments? It's a great question.
We can. We absolutely can. There may be other programs in the state that have done that. We haven't. I will say the overwhelming majority of our referrals are in the geriatric population. I do know that our county public health office does have a pretty good neonatal, new mother, maternal child health program, I believe is the actual term for it. But yeah, certainly can bridge that gap. Any program can for sure.
And then can individuals or families self-refer to the program, or what does that look like?
Yeah, with our program, they can. Again, it's going to be program specific, so definitely reach out to your area to AC if you have a program. And then, B, what their parameters are. What we do when we get a referral from families, friends, coworkers, those kinds of things, is we do need to connect back with the primary care physician. We have to have that closed-ended loop. We just can't go assess and, oh my God, somebody's blood pressure is 200 over 100 and say, have a great day. We've got to be able to close that loop with, generally with primary care. Patient doesn't have primary care. That's one of the things that we help navigate to try and figure out. Certainly, all of these programs have medical directors. We have a medical director that was in the emergency medical space for a very long time, and then has transitioned into the community paramedicine space specifically, and has been there for the past 7 or 8 years. So, we're able to bounce those things and be, again, flexible and change our protocols and how we address those. But yeah, I mean, referrals are the way that we keep this going, and we can always find ways to connect the dots. Real quick, where do things stand today? Funding. Most community paramedicine programs are still funded on grants or foundations, those kinds of things. Several initiatives are underway to work with payers. There's the federal legislation to get CMS involved. There's a link there. I'm going to send Jennifer, Aiden and I talked about, we're going to send Jennifer a whole bunch of links to different things. So maybe she can push that out in a group email with all of these things that we're referring to there. The Putnam County-wide program that just being launched. Putnam County is now doing a county-wide community paramedicine program. Now, I know there's other county-wide programs that are out there being covered county-wide. This is actually funded through and contracted through the county, through the municipality. Empress is the provider there, and as part of their ambulance or their ALS contract, they're actually doing community paramedicine. So again, this continues to grow and to become part of what EMS and healthcare is being, healthcare is locally. At the bottom in the little green highlighted area, unofficially, because there is no great way to get this data, less than 10 of the 55 approved community paramedicine programs that have been approved by the Department of Health are actively doing community paramedicine in the sense of what I've explained here. So what does that mean? Aiden's going to talk about something here in a little bit that really needs your advocacy. It means that this doesn't happen everywhere. If you're interested in it, you should reach out to your local EMS community and see if they're doing it. If they've been approved to do community paramedicine, but they're not, maybe light a fire under their tail feathers and get them doing stuff. But yeah, it's not a great return on the investment. I will say those that are doing it are killing it, are working really hard to make it happen. So find out if they're doing it, and if they're not, kick them to go. Okay, Aiden, you can just bounce through this again. Please, please, please advocate when the regulations come out. And I'm going to hand this over to my esteemed colleague from the Columbia County, Mr. O'Connor.
Thank you very much, Mark. And I think I could probably speak for everyone. I get super motivated when we talk about this topic, just because there's so much need for it and it exists today. Now we just need to figure out how to expand it, right? I bet everyone on the call, and I was looking through the attendance list, we have stakeholders from so many different varying sectors. We have public health, we have the Matters program, we have great consortiums, our local Columbia Green one, which is wonderful here. We have hospitals and mental health, addiction services. I say that because I'll highlight something Mark said early on when he was introducing the topic, is EMS has always been in the public safety realm, but we haven't really been in the public health realm. And I think, to his point, COVID pushed us in that direction where we could sit comfortably in both. We could be with our fire, police, and 911 partners while also being very comfortable sharing data, because we share the same patients, we share the same issues. So it's exciting to see that this could be that solution that binds all of this together. I'll mention one thing on this slide, and then the next 3 slides that I have are just very tangible for all of you, because one of the things Jennifer mentioned last week, we were in the National Rural Health Association in DC, and a lot of topics came up about community paramedicine and mobile integrated healthcare. But the biggest thing I think was asked about us, for Jennifer and I, was how do we get this in our community? How do we get this in our state? So we're going to give you some really tangible bills, legislation, regulations, and things that we could do today when you log off this to help champion this service. The one thing I'll say when it says regulations are key is EMS today operates under Article 30, which was written in the 1970s. It was written just to respond in ambulance. Somebody calls 911, ambulance responds, we attend, and we go to the hospital. There were no other thoughts outside the box of where we are today in 2026. So regulations will be key, which if we go to the next slide, Jen will be able to highlight some of those. So tangible things here in New York State that we're monitoring. The good news is we have legislation on the docket. So we have Senate bills listed there, and the Assembly Bill 5333 and Assembly Bill 1309, and that is to strengthen the community paramedicine model as it is today. That is both advocated on behalf of the Rural Health Association as well as the New York State Volunteer Ambulance and Rescue Association. I did put a kind of a ancillary bill on there as well, which is the buprenorphine bill for substance abuse disorders. As of today, when we go out and we administer Narcan and we see patients, and sometimes to Mark's points on data, we see frequent users of the system, we have the opportunity to administer buprenorphine. In reality, it's in the protocol, but unfortunately, it's a reg change that we'd have to make to have paramedics stipulated in there to have that. It's another ancillary bill that if we had that option, we can keep more people out of the hospital. So I did list that on there as well, both the Senate and the Assembly bill. This year, for the 2026-2027 executive budget, there was wording in there for community paramedicine. Thanks to a lot of great people out there who worked with the governor's office and the Senate bill and the governor's office with the budget are sharing the same language. That will help expedite the process. That'll help make sure that the wording really gives us the opportunity to access things that Mark and others are doing here in New York State. I will give a shout out on March 25th. There's going to be a day up in Albany. The Legislative Commission on Rural Resources meets once a year to bring together all the different healthcare organizations throughout the state. And they've really prioritized community paramedicine. When they laid out their 2026 agenda items, they did mention community paramedicine right out loud in their videos and on some of their resources. So big shout out to them, both the Senate and Assembly working on that. The last thing I'll mention is something that I think is more of a framework, right? So we talked about this, but how are we going to pay for it, right? How's the long-term sustainability? Mark mentioned that they're mostly on grants now, right? It's not a Medicaid, Medicare funded. There's no private insurance funding. And one of the things I'll mention, because it was mentioned early on, was the Rural Health Transformation Grant, which we all are watching very closely across the country. And New York State's $212 million that's coming. We couldn't even apply for that under the community paramedicine model when it was being put forth to the federal government, because regulatorily wise, we couldn't do it today. So it would be, it kind of negated itself out. So one of the things that did pass in 2025 is treat in place. So as of today, if somebody goes to a 911 call and we were to treat a diabetic with glucose and an IV, and the patient didn't want to go to the hospital and stayed behind to follow up with their doctor, before we were doing that at $0 charge. Now there's an opportunity for Medicaid to reimburse that, which we look forward to going live in 2026. And I think that once the regulations change, that will be the framework to then turn to Medicaid and say we could pay for this community paramedicine model under that same exact framework with a very quick change in legislation. So very exciting to see something more sustainable funding come out of that. The last thing for the state level is be on the lookout. I know it was mentioned, but as many positive comments, it doesn't have to be from your organization. It certainly could be if you want to put in a letter on behalf of the organization, but individuals could also put that, and those positive comments will be essential for us to pass those. The next slide over is just to mention the federal side, because they are also looking for ways across the country to unify this across all 50 states. There is legislation right now, HR 4011, the Community Paramedicine Act. This really is helping with the funding mechanism as well, putting some dollars behind some of those initiatives that Mark and other organizations we just heard of are doing this. So I would say that nice thing about this, if you go to the National Association of EMT website, nemt.org, right to the right of that on the picture on your screen, there's a little button that says Take Action. If you were to click on that button and put your zip code and information in, you could automatically get a letter sent to your Congress member. You could ask for a Senate bill and some Senate sponsors, as well as to both Congress and Senate and Department of Health, things like that. So very easy to take action on. The second thing is that treat in place model that Medicaid and the state passed. They're also pushing that for the Medicare model. And again, that would really help us with that long-term sustainable funding if that was to pass in the Medicare and federal line as well. And for those who may be interested in really pushing this, it is on the agenda for the EMS on the Hill Day in Washington, D.C. on March 25th and 26th, where we'll be going to meet with Congress members and senators to really push home to pass this community paramedicine model in 2026. And last but not least, as we talk about resources, we wanted to leave this with you. And certainly we'll talk to Jennifer about sending this out with some of the links. But the report on rural ambulance services did just come out. The governor's task force put together, lasted about 2.5 years, Mark, correct me if I'm wrong. Probably one of the greatest groups I've ever had the honor to serve on, got to work very closely with Mark and get to know him in that setting. But this talks quite a bit about mobile integrated health and community paramedicine model. So if you're looking for that resource to go back to your county, and whether it's a board of supervisors, whether it's a county legislature, whether it's a regional project, whether it's grant funding that you may be looking for, or even your EMS agency who may not know this exists yet, you could take this with you and say, here, read this, here's the model, here's kind of a summary of what was said and talked about today. So it's a great document. Happy to email that out there and spread the word. And Jennifer, that concludes the legislative side, so I'll turn it back to you and Mark.
Well, I'll stop sharing my screen for a moment, and if there's any questions or comments, or if there's anything you want to ask, I think now is that time.
Hi, Jennifer, I don't know how to raise my hand, but
You're off mute. Go ahead, Brian.
all right. Mark and Aiden, fantastic work. Thank you so much for this presentation. I'm a physical therapist located in Bloomfield, just south of Rochester, New York. And I deliver telehealth. And it's not uncommon for me to get a call from somebody with kind of raging low back pain that can't think about even getting out of their house. No problems with bowel or bladder function, none of those red flags, cauda equina, anything like that, but don't really want to go to the emergency room. And somehow they find me. I'm able to put them through an assessment to get them on that path to be able to at least get out of bed and moving and so on and so forth. So I'm curious to know, how often you may confront that scenario, and when you do, what options do you currently have? And I'd be glad to talk to you more about it offline. I'm just curious. Thank you.
So, I mean, that's not necessarily something that we see, those types of things, especially in the community paramedicine to start with. We do see it from a 911 perspective, right? People call 911 and to some level, our hands are tied. And I think, Aiden would agree that, if the patient says, I need to go to or I want to go to the hospital, we have to take him to the emergency room. So can there be pathways to address this? And the answer is yes. There is a program out there, one of the community paramedicine programs in the state, actually Northwell Health's program, which is, in the southern part, the island and part of the city. Theirs is based on 911 calls. So they actually send community paramedics to lower acuity, or even some high acuity 911 calls, go assess, treat, and place. What's nice about Northwell is they're a payer, they're a hospital, they're a healthcare system in general. They do the treat and place aspect of it. I think that, to me, that's a fantastic opportunity. I think if you had patients like that, creating a partnership from a community paramedicine program with somebody like you that, has access to those patients, you're going to do it by telehealth. And you want somebody to go put eyes and ears on the patient. You want somebody to go in and do that, as opposed to doing the assessment telehealth wise. You can do the assessment telehealth while a community paramedic is physically there to gather additional information, and then you can, implement that care plan. So, some of the apprehension in doing things like that in a 911 perspective and then not going to the hospital is the overwhelming number of EMS agencies in the state. Their primary source of revenue is transporting patients to the hospital. We don't, and Aiden talked about, TIP and TAD, treatment in place and transport to alternate destinations. We truly, on a 911 call, we do not generate a nickel of revenue until that patient's in the back of the ambulance, the wheels on the bus are turning, going towards the emergency room or going towards a hospital. So when we don't transport, we don't generate that revenue. And if you're not supplemented with municipal funding, then some people are apprehensive to do that. But I think, Brian, I think your example is a phenomenal opportunity to partner with somebody in community paramedicine to work together.
Great. Thank you. Yeah, I'll be in touch.
And maybe, Brian, just to mention, we did, right after COVID, we had a telemedicine company who went out to EMS, and when they called 911, to Mark's point, it was more of a reactionary versus proactive, but we'd go to a scene for muscle or back pain, chronic. We would be able to go on telemedicine, speak to the doctor, administer Toradol, IV, assess them, and then they would do a follow-up thereafter with PT or OT, and it worked phenomenally. To Mark's biggest point, it was kind of counterintuitive that our model then doesn't reimburse for it, and B, the funding ran out, so there wasn't long-term sustainability, so that telemedicine aspect went away. But I think you're spot on. I think that is the future 5 years from now.
Thank you.
Mark, we have in the chat, do residents have to sign up for their local community paramedicine program? I know there's programs that are limited throughout the recommendations on that.
I don't believe so. None of the programs I know, the programs that are all referral based. Can they self-refer? Certainly. It's just establishing that that relationship with some sort of end care provider, whether pre-CPologist or something of that nature. But yeah, certainly most programs are marketed. They may not be marketed to the general public as an ambulance service would be for emergencies, but they're marketed to primary care specialists, hospital systems, other healthcare systems. There's some behavioral health work that's being done as well. Some pretty significant work there. There's work in substance use disorder in some programs. So yeah, it's become pretty broad.
I'll just say too, while folks are thinking about it, if there's any questions, when I worked with Mark, one of the things that really amazed me too, doing a ride along, teaching an elderly woman to be able to order her groceries online and to be able to order her medication online was huge for somebody who was homebound, and just the care and the authenticity of the staff that's going there and working with people is phenomenal. So just wanted to call that out. I think when we think about some of our folks that are homebound or maybe don't have the support systems to get to where they need to be, it's people like Mark and Aiden's team that are really out there supporting on the day-to-day. And I think about that all the time, and I still tell that story. And teaching her how to use Facebook to interact with her grandchildren too.
We have
So we did have Janai drop.
We have a
Oh, sorry, Mark.
we have a CPIT, that goes out and does social media and gets their apps and, their Grubhub and all that kind of stuff.
Yeah. Crowning achievement of my life, teaching someone how to use DoorDash. Are there any programs that utilize EMTs?
They all do. Yeah, community paramedics are really just the paramedic is the nomenclature for all levels. Believe it or not, the United States is the only country in the world that separates us out like this. Every other place, all emergency service, medical service providers are paramedics, just at different levels. But yes, we use EMTs, advanced EMTs, and paramedics.
And maybe to add on to that question too, there are a lot of services nationwide that are starting to incorporate PAs, nurse practitioners, even physicians as part of that whole model, and certainly with the mobile integrated mental health and addiction services as well.
We did have Janai dropped into the chat the link that Aiden had in a slide deck about supporting mobile integrated healthcare. So if you want to click on that link and weigh in with your member of Congress, that would be great. The one thing that I will call out is members of Congress do have a filter on their email. So if something is not made unique, it goes into a hole far, far away and never is seen by the light of day. So it's really imperative and important that when you're reaching out to your member of Congress specifically, to just personalize it just a little bit, put in your name, where you live, things like that will trigger or will not trigger that filter. I'll also just add that NYSARH is supporting, for those of you who are on NYSARH's policy committee are aware of this, but we are supporting 3 different community paramedicine or first responders pieces of legislation. So I'll just share that real quickly. And if you're a NYSARH member and want to use this with your member of assembly or state senator, we highly encourage that. So you'll see right here, we have support for first responders, closing that Medicaid payment gap, the first responder peer support legislation, and as Mark and Aiden discussed, the strengthening the community paramedicine program. So really excited to see what the Assembly and Senate one House budget bills come out with, hopefully the first week of March, but we're fairly confident with our advocacy that we'll get some great language in both one House budget bills. And if you're interested in joining the NYSARH Policy Committee, feel free to reach out to me. All right, well, this was a wonderful discussion. Mark, Aiden, I can't thank you enough for coming and sharing your wisdom and your lived experience. We had a great turnout today, so thrilled for everybody to come out and learn a little bit more. Thank you so much for your time today. I know everybody's schedules are at capacity, so we appreciate you spending the time with us today. Oh, I love all the claps. They're not for me, they're for Mark and Aiden. So thank you so much. I know we're just at the top of the hour. We got 5 minutes till 2 o'clock, probably your next call. So use this opportunity to go get a glass of water and step outside. Everyone have a wonderful rest of your day, and we'll talk soon. Thank you.
Thank you.